Cancer. Warm regards from Bayer Oncology. Today we have Dr. Krishna Chaitanya sir. Sir is a professor from MNJ Institute of Oncology and Regional Cancer Center. He is a consultant medical oncologist. So over to you, sir.
Good evening, everyone, and thank you, Bayer and Sandeep, for that opportunity and the kind introduction. So today we would be discussing on the prostate cancer, the landscape of the treatment, and most importantly, we'll be discussing on the metastatic HSPC, how the treatment has changed in the past, 3-4 years, what we are doing right now practically in the clinical practice, and how important is to detect the subset where they need treatment intensification, where we can avoid unnecessary treatment, that is just going with a doublet. The aggressive subset would be where we'll be treating with the triplet. So these things will be discussing now with the evidence and the case based discussions. So for this, I would like to invite both our speakers for today, that is Dr. Venugopal, who will be talking on the treatment paradigm in the MHSPC, and as well as Krishnamani sir for the Aranote study, the study details, and as well as the case presentation from him. So with this, I would like to invite now Dr. Venugopal to take over and go ahead with this presentation. Venugopal sir, you are there?
Hello.
Sir, you're audible, please.
Okay. Let me share my slide deck. Yeah. Yeah. Hi, everyone. Good evening. Thank you, Bayer and Sandeep, for this wonderful meet today evening. So we'll be going ahead into the talk without wasting much time. So today's I'll be talking on metastatic HSPC. Yeah, treatment paradigm, how we have evolved over a period of time, right from just ADT to a multitude of options. So this is the prostate cancer landscape as we see here. So localized or locally advanced prostate cancer, and which evolves into non-metastatic CRPC or after ADT exposure into the metastatic CRPC. And today I'll be speaking on newly diagnosed hormone sensitive or castration naive or castration sensitive metastatic prostate cancer, the treatment options. So ultimately, as we know, so at the end of the day, patients who suffer and die of prostate cancer all have the castration resistant prostate cancer. So ironically, we know that whatever we do, the OS improvement is only about by 2.5 to 4.5 months in this CRPC setting. So what we actually need to identify here is any case when we see the newly diagnosed metastatic hormone sensitive castration naive prostate cancer. So that is the area where there is opportunity to delay metastatic CRPC and further improve the outcomes rather than dealing with the actual frank CRPC patient. Yeah, this is the way back data what we have in our hands always. So this is the Stampede trial in which, as we know, the control arm is ADT alone. So as we can see clearly here, if you give ADT alone for these patients, the 11.2 months is the time frame at which they progress to CRPC, and a median of around close to 3.5 years is the overall survival. So which definitely for a disease like prostate, it is very suboptimal, we can say, when we deal it with only ADT. So we can do now much better as we go through, we can see. And also, interestingly, as we know, this is the Stampede data. So is there any benefit of addition of the local radiation to prostate? Yes, there is a subgroup of patients, those who has low volume, less than 4 bone mets, they definitely have some benefit, definitely with the addition of the local, radiation to the prostate, hazards being 0.56 in terms of failure-free survival and 0.64 for overall survival for low volume patients, definitely not for high volume patients, those who have 4 or more than 4 months. As we clearly see here, hazards in terms of 0.86 for failure free survivals and 1.12 for overall survival with the addition of the radiation to the prostate, that is local radiation. Yeah, so this is the multitude of options what we have in our hands, and this is the time frame line which shows the options in terms of docetaxel in this setting from CHARTED as well as GETUG trial data and STAMPEDE as well. And we have abiraterone from Latitude and STAMPEDE arms as well. And enzalutamide, the data comes from ARCHIS and ENJAMET, and now of course apalutamide for Titan, and more importantly darolutamide will be talking from the PEACE-1 and ARASENS. So what do we choose? So we'll go one by one. So docetaxel in metastatic hormone sensitive prostate cancer. So the overall survival, as an oncologist, as we know, that is the gold standard point, endpoint what we look. And in the similar way, if you look for docetaxel combination with ADT versus AD2 alone in high volume versus low volume, if you see high volume patients, metastatic hormone sensitive, hazards are 0.63, p-value is significant, and improvement is close to 16 months when you add docetaxel to the ADT backbone in those patients who have high volume. Whereas low volume, as we see clearly here, hazards are 1.04 and improvement is almost nil when you add docetaxel to the ADT backbone in the low volume patients. And abiraterone data comes predominantly from Latitude in high risk metastatic HSPC. As we see here, at a median follow-up of 51 months, if you add abiraterone to the ADT and of course in combination with prednisolone versus ADT alone, so as we see here, 53 months of overall survival versus 36 months, hazards being 0.66, that is significant benefit in terms of overall survival if you add abiraterone to the backbone of ADT. So it was the first effective. However, we need to understand when we are treating prostate cancer like patients, the long-term treatment implications, and we need to understand the journey, of course, in terms of the toxicity and safety profile. So this is what, even if you add abiraterone, when you are doing abiraterone and when you add 5 mg prednisolone alone, as you can see clearly here, the toxicity in terms of hypertension, grade 3, grade 4 amounts to 23%, and hypokalemia 12% if you add just even 5 mg prednisolone. So of course, we need to remember that these are all elderly patients, cardiac disorders, fluid retention, edema, and osteoporosis, all this because of the steroid addition. So we need to remember all these facts before we pick and choose an agent, that is with respect to abiraterone. Next, let us have a look at apalutamide. Yeah, so this is apalutamide plus ADT in metastatic HSPC. So we have improvement in terms of PFS and OS, hazards being 0.48, 0.65 respectively. And more importantly, low volume and high volume patients also had good hazards, 0.36, 0.53. Whereas enzalutamide, definitely improvement in terms of PFS and OS when you add to ADT backbone. But there is a concern telling us that low volume only had that benefit, whereas high volume, the hazards are 0.80. So we do think twice when dealing high volume patients when we want to add enzalutamide for these patients. So next is combining therapies to further improve the outcomes. Yeah, so this is the PEACE-1 data, what we have, just let me. Yeah, so PEACE-1 addition of abiraterone to ADT plus docetaxel backbone, or the standard of care is ADT plus docetaxel. Whether you add abiraterone or doesn't add any benefit, that's what we are going to see. High volume disease, standard of care alone versus standard of care plus abiraterone. If you add abiraterone to the ADT plus docetaxel, so is there any benefit? Definitely yes. So as we can see clearly here, so there is significant benefit when you add abiraterone, hazards being 0.72. So you could improve the outcomes by the addition of the abiraterone to the docetaxel than giving docetaxel alone for those patients who had high volume disease, and in low volume disease hazards being 0.83 and confidence intervals crossing 1. So definitely it didn't seem to be as beneficial as the high volume disease to add abiraterone to the ADT plus docetaxel. That's what the PEACE 1 data tells us. Yeah, next, coming to the today's topic, ARASENS. So by design, it's a global randomized double-blind placebo-controlled phase 3 study where close to 1,300 patients metastatic PC setting, ECOG PS01, and those, most importantly, what we need to remember, those who are candidates for ADT and docetaxel alone were randomized to receive docetaxel plus ADT versus docetaxel plus ADT plus darolutamide. That is darolutamide plus placebo, daro versus placebo. That's what we are looking at in 1:1 randomization. And the stratification factors were extent of disease and alkaline phosphatase levels as well. The endpoints of the study is, the primary endpoint is overall survival. Secondary also most important, we have time to castration-resistant prostate cancer, time to pain progression, symptomatic skeletal events, and time to first symptomatic skeletal event, all that, and time to initiation of the systemic antineoplastic therapy. So these are all the secondary endpoints, the primary endpoint being the overall survival. So 87% of the patients received all 6 cycles of docetaxel, meaning that, so even if you are giving daro, it doesn't interfere with the docetaxel for the patients. So adverse events between the arms were almost identical, telling us, giving us information how safe darolutamide is. So if you look in terms of the primary endpoint, overall survival, so this is overall population data, daro versus placebo. So at the end of almost after 4 years, 4.5 years, so 63% of the patients versus 50% of the patients who survived with daro versus placebo, hazards being 0.68. So the p-value is very significant, telling us that there is significant reduction in terms of death almost by 32% when you give darolutamide versus placebo alone. That is ADT plus docetaxel alone. So, and when you look in terms of how the high risk patients did and how low risk patients did, again, both these risk patients did well with darolutamide when compared to ADT plus docetaxel alone. So hazards being 0.71 and 0.62 in these patients respectively, high risk and low risk. So benefit is seen across all subgroups, whether it is high risk or low risk. Overall population had got the benefit in terms of overall survival with darolutamide plus ADT plus docetaxel versus placebo plus ADT docetaxel. So, and when you look at key secondary efficacy endpoints, so time to CRPC is significantly better with darolutamide versus placebo. So not estimable versus 19 months. And time to first subsequent antineoplastic therapy is also significantly delayed by darolutamide addition, 61% risk reduction, and time to pain progression, 21% risk reduction, and time to first symptomatic skeletal event also much better with darolutamide, almost 30% risk reduction. Yeah, so we need to understand the importance of the PSA response and outcomes by the PSA response. So undetectable PSA levels, so if you add darolutamide at any time, 67% had achieved undetectable PSA levels when compared to almost close to 30% with ADT with docetaxel. Us that patients who has received undetectable PSA levels almost close to 68%. And what is the benefit? What we are looking at? So time to PSA progression undetectable PSA at 36 weeks versus detectable PSA at 36 weeks. If you look, as you can see clearly here, so event-free probability is much better for those patients who have achieved undetectable PSA at 36 weeks. So hazards being 0.23. And even if you look overall survival, those who have those who had undetectable at 36 fared much better than who didn't have undetectable, at 36 weeks. Hazards again being 0.37 for overall survival as well. And when you look again by high volume for these PSA responses and outcomes, definitely, so the undetectable versus detectable event-free probability is better. Hazards 0.20 for those patients who had undetectable PSA in high volume as well. And overall survival also is much better. Those patients who has achieved with darolutamide, hazards being 0.3 versus ADT plus docetaxel alone. So in essence, telling us that darolutamide triplet achieved long times of disease progression and also significant improvements to the overall survival. Time to CRPC and OS benefit with darolutamide in these patients. Again, reflecting the same data in the low volume patients also, hazards being 0.34, event-free probability and OS as well. So what we need to remember here is, so patient who are able to tolerate, and 3 points my end. So when you look at as an agent, darolutamide versus enzalutamide versus the apalutamide, so Daro has very good safety profile because most importantly, it has minimal CNS penetration. So that's why they have less amounts of fatigue, less risk of seizures, and minimal drug interactions. And more importantly, as we know that prostate cancer patients are elderly, so they're all on polypharmacy. So minimal drug interactions is what we need. So less risk of falls, less risk of seizures, less risk of polypharmacy interactions. All these as an agent, all this actually benefits our patients with darolutamide. So patient able to tolerate and accept docetaxel, definitely triplet is the way to go forward. Darolutamide plus docetaxel plus ADT for HSPC metastatic patients, and high volume, high risk extent of disease also, because we know that they are likely to have hormone insensitive clones hit hard first. So again, triplet telling us the benefit of triplet. And those patients who are young and fit, definitely triplet is the way to go forward. Hit it hard and early because CRPC is very tough to treat and get maximum benefit, and patient needs to be informed of the options definitely. So I think with that, I'll be ending my talk here. Thank you all.
Thank you, sir, for that crisp presentation on the metastatic HSPC. Who are the patients require triplet, and you have clearly, shown the difference between what the evidence what we have with the abiraterone in peas and darolutamide in narations, and you also spoke about the side effect profile of the drug, and you clearly mentioned whoever is like fit for docetaxel, it has to be a triplet therapy. Now we don't talk about a doublet with the docetaxel at all. So it's totally out. If it's a doublet, it's just the ARPI with the ADT. If a patient is the subset which is belonging to a high volume, high risk disease, definitely they require a triplet, and the drug to be combined with docetaxel would be darolutamide with the robust evidence what we have in Arasens. Thank you so much, sir, for that. And now I would like to invite Krishnamani, sir, to talk on Aranote.
Thank you, Dr. Krishna Chaitanya.
Sir, I'm sharing this screen, sir. 1 minute. Venugopal, sir, can you stop sharing the screen, sir?
Yeah. Stop, Sandeep?
Yes, sir.
Oh, thank you.
Sir, please. Go ahead.
Yeah, am I audible?
You're audible, sir.
Evening. Good evening, Chaitanya, Gopal. We'll be talking about hormone-sensitive metastatic prostate cancer and the role darolutamide has to play with respect to the ARANOTE trial. Next slide. So this is all the data which we have over the last 12, 13 years. So I would just like to brief all our learned audience on what these trials are all about and why did this actually come into force. So the days during our residency, leuprolide alone or a GnRH analog with bicalutamide was the treatment of choice in the treatment-naive metastatic hormone-sensitive setting. Then came a philosophy that you add chemotherapy. That was the Chartered trial. So adding chemotherapy gives benefit. So the Chartered said, add docetaxel, you have a benefit. And in whom do you have the benefit? In high volume disease. So then the concept of volume of disease came. High volume versus low volume. High volume is those who have visceral metastasis or more than 4 bony lesions, one outside the hip or the spine. Then the Latitude trial came. They put up something called a high risk, where they included these two criteria also with the biology of the tumor, which is the Gleason score, 8 or more. And then the Stampede had multiple arms, where they had an abiraterone arm, they had a radiation arm. So the Stampede finally said you can give abiraterone, it gives benefit to all comers, that is low versus high volume. And then you had newer drugs like enzalutamide, apalutamide, then the darolutamide. So all these, the Enza trial is the Arches trial, the apalutamide is, as Dr. Venugopal said, the Titan. Then the triplets started. So as Dr. Krishna Chaitanya very beautifully put, triplet is for people who can tolerate docetaxel, number 1. Number 2, who are fit enough. Number 3, who have high volume disease. Doublet, you have any of these 4 options to choose in those who have low volume disease. So we'll try to keep it very simple. Next slide. Yes. So there is an unmet medical need with a good safety profile. And that is beautifully illustrated by Dr. Venugopal, because we have elderly patients, we have patients, one second. Am I audible?
Yes, sir, you're audible.
Sorry, yeah. So why do we have this unmet need? Because as Dr. Venugopal said, see, most of our patients are the elderly group. They are prone for falls. They have concomitant comorbidities. They are on polypharmacy. So you require a drug which has less interactions. And in that way, darolutamide has proven that it has a less of a CNS penetration and is much safer compared to Enza, which has a high risk of falls and seizures, and apalutamide, which has a risk of skin problems and hypothyroidism. Now, the 2 pivotal trials, one is the ARASENS, which Dr. Venugopal said, it's a phase 3 triplet, which showed the benefit in high volume patients. And then the ARANOTE, which we are going to discuss, is a doublet, darolutamide plus ADT, purely from a safety point of view. And with this ARANOTE data, darolutamide has the potential to change the treatment paradigm, as now it would be the only ARI which could be used with and without chemotherapy. Though we use abiraterone with docetaxel or without docetaxel, but darolutamide evidence is more robust, and the darolutamide evidence is more efficacious than abiraterone in its evidence to bring down the PSAs to a subnormal level. Next slide. So
we spoke about Arasens and why did the ARANOTE was done. ARANOTE was designed to evaluate darolutamide plus ADT versus ADT to provide a new treatment option. Next slide. So what is a study design? So basically, you need to have prostate cancer, so biopsy proven adenocarcinoma. You need to be hormone sensitive. You need to have metastatic disease. CTs or MRIs were done. PSMA PETs have not been done as part of routine evaluation. So there could be a staging bias there. Good performance status and good organ function. And stratification was visceral mets, that is low volume versus high volume, prior local therapy. So based on these criteria, the patients were stratified into a group which received ADT plus placebo and another group which received ADT plus darolutamide 600 milligram twice daily. The primary endpoint was radiographic progression-free survival. Secondary endpoints was OS, time to initiation of subsequent next therapy, time to castrate resistance, time to PSA progression, the rate of undetectable PSA, which I spoke about, less than 0.2, safety, etc. Next slide. So you look at the DARA group versus the placebo group. 30% of patients were Asian. They had a good, so almost a third of the patients had an Asian population. If you look at the Asian population, 31.6%, Latin America is 26%, Europe and rest of the world is 41%. So it is a data which applies to our local population compared to other Western studies. The Gleason score more than 8 at initial diagnosis is 70%. So it actually takes in a lot of high-risk patients. The median PSA is 21.4. De novo metastasis is 70%. Recurrent disease was seen in 32. High volume, 70% patients. Visceral mets in 12%. Prior local therapy was allowed in around 18% of the patients. So you would agree that the study included a lot of patients who had high risk, high volume disease, which is close to 70%. And please understand, high risk, high volume patients tend to progress within a year if they are put on ADT alone, 13 months or 14 months to be precise. So that is precisely the reason of advancing therapy, not when they develop metastasis, but even prior to that. That is a baseline so that these patients can survive longer with an acceptable safety profile. Next slide. Now, when you look at the country representation across the clinical trials, now look at ARANOTE. China contributed close to 14.5. India is the next one, around 14% of patients. Taiwan 3.5. Australia 4.5, and New Zealand around 2%. So we had a good amount of patients who were from, who were represented from the Indo-China axis, preferably almost around 27 of the 32% of the patients. Next slide. So it is representative of our population for which we can actually talk about. Now, looking at the primary endpoint, what has it done? It significantly reduced the risk of radiological progression by 46%. So the hazard ratio was 0.54. So what we are looking at is, we are talking about a non-metastatic setting. So our primary endpoint is, when will they develop metastasis? So the radiographic progression-free survival. The median follow-up was close to 2 years. And in that way, it significantly reduced the risk of progression, and it had reached its primary endpoint of RBFS. Next. Now, the benefit which was seen across the subgroups, including patients with the high volume, low volume, across the race, white versus Asian, geographical region, visceral metastasis, across baseline high PSAs versus low PSAs, etc. So DARA addition to ADT, the benefit is seen across all comers, more importantly, high volume versus low volume. Next slide. So across all the secondary endpoints, now look at the OS. The median OS was, so if you look at the median OS, look at the time to metastatic castrate resistance, time to PSA progression, time to initiation of subsequent therapy, all across the board, DARA is superior compared to placebo. So at the time of primary analysis, the OS data are immature, but it has achieved most of its secondary endpoints too. Next. It delayed the time to CRPC and time to pain progression, which is important from a patient point of view, because as Dr. Krishna Chaitanya said, see, once you develop castrate-resistant prostate cancer, it's a downhill for a patient. So if you look at DARA ADT versus placebo ADT, the hazard ratio is 0.4. There's a 60% reduction in the risk in progression to castrate resistance, or also in pain progression, which would obviously mean less need of analgesics or less need of palliative RT to these patients. Next one. PSA less than 0.2 at any time during treatment. This is what I was alluding to initially. When you compare these newer agents with the older agents like the Latitude trial of abiraterone, their efficacy in reducing the PSA to less than 0.2 is much higher. And that is considered a surrogate of a deep response and a long-term durable response. So 63% of patients in the DARA doublet attained a PSA less than 0.2. This represented a 69% improvement in time to PSA progression. So it scores over placebo in reducing the PSA to a subnormal level or a deep and durable response. Next slide. A higher proportion of patients in the high volume and low volume subgroup. So when you look at the patients achieving the PSA less than 0.2 in the DARA group versus the placebo group, even in the high volume group, across time periods, and in the low volume group, darolutamide with ADT was able to suppress the PSA to a much lower level compared to the placebo group. Next slide. Now, subsequent life-prolonging anti-cancer therapy. Now, once you progress on any of these ARPI, you are going to be put on subsequent therapy in the form of docetaxel or cabazitaxel, etc. So, the number of patients who discontinued darolutamide, discontinued study treatment, is 45% versus 71%. Patients who required subsequent anti-cancer therapy is 32 versus 42. Docetaxel, 22% of the patients received compared to the placebo group of 28. And then the other agents were 12% patients had received abiraterone, a minuscule of patients had received the other ARPIs, and then radioligand therapy 1% versus none. So the subsequent anti-cancer therapy, the need for that is lesser on using darolutamide upfront compared to placebo. Next. Now, the incidences of treatment emergent adverse events were similar between the treatment groups, and discontinuations were lower in the darolutamide arm. We saw that. The worst grade 3 or 4 was seen in 30%, grade 5 was seen in 4% and 5%. So the safety profile was independent of the response, not that you got a greater response, so you're going to have a poorer safety profile. And it was consistent with the triplet arm or the Arasens arm and the Aramis arm. Aramis study is a study of darolutamide in the node positive setting or the metastatic castrate, non-metastatic castrate resistant setting. So in those two studies also, darolutamide has been used and the safety profile was consistent. So there were no new safety concerns in this study. Next. Most of the adverse events were low and similar between the treatment arms. One important thing is fatigue, which was seen in close to 5.6% of patients versus 0.5% of patients. Hypertension is something which we see commonly with these agents, but the beauty of darolutamide is, as Dr. Venugopal said, the history of falls, history of CNS penetration, history of seizures, polypharmacy interactions are all much lesser compared to the enzalutamide or apalutamide. The only thing is a double daily dosing, which patients should be prepared. Next slide. So the rates of adverse events are commonly associated with similar across treatment arms, which we just spoke about. I'll just rush through this slide. Next slide. So it has a positive impact on the quality of life. It extended the time to deterioration by 5.1 months in the FACT-P score. It's the first and only inhibitor to demonstrate meaningful delay in pain progression, overall well-being. Patients felt better as regards to their pain and overall quality of life. Next slide. This was presented in 2025 ASCO and demonstrates clinical and meaningful delay in the deterioration of well-being, especially on social and functional and urinary symptom domain also. Next slide. So all these things favor darolutamide. Now, coming to the end of my talk, I just added a couple of slides for the benefit of any residents or some of my other colleagues who are here, so that we'll just brush up with all the multitude of data which is there. Now, I'll proceed from the node positive realm. There are multiple studies, the Spartan study, the Aramis study, the Prosperous, the enzalutamide study. There are a lot of studies which have looked at all these three ARPIs. What I would like to highlight is node positive was excluded in the Prosper study, and in the Spartan and Aramis, 16% of patients were node positive, and their criteria for node positive was the node has to be below the aortic bifurcation and less than 2 centimeter pelvic nodes were allowed. So if you are looking at using any of these agents in a node positive setting along with ADT plus RT, then I think we have to choose between darolutamide and apalutamide and not Enza, because Enza trial, the Prosper trial, did not take node positive patients. Next slide. And as Dr. Krishna Chaitanya very beautifully pointed, this is a multitude of all the trials. Chartered told us what is high versus low volume. Latitude, on the other hand, told us what is high risk. High risk is not high volume. There could be an 80% concordance, but high risk also includes Gleason more than 8. Venugopal very beautifully said, Stampede has proven that radiation to the prostate has an OS benefit and also obviously local control and local symptom control. Stampede also beautifully told us that Abiraterone works. As Dr. Krishna Chaitanya said, low volume doublet, gone are the days of Dosi. High volume triplet, if your patient can tolerate the docetaxel. And PEACE and the Arasen study are the triplets, and in the high volume it gives you an OS benefit, in the low volume it gives you a PFS benefit. The PEACE study, like the Stampede, also looked at the addition of local radiation despite having metastatic disease. So in low volume metastatic disease, giving RT to prostate has a PFS benefit. So this is summarizing all the data which is there in the node positive, in the castrate sensitive, and the metastatic and the non-metastatic space. Next slide. So finally, to conclude the ARANOTE study, DARA plus ADT has improved the PFS in the metastatic hormone sensitive prostate cancer patient. It shows benefits across all its endpoints like overall survival, like time to castrate resistance, time to PSA progression, quality of life endpoints, etc. Deeper PSA and durable PSA response, pain progression, social, family, quality of life, urinary symptoms. It has proven a role and has a favorable safety profile. So DARA plus ADT without DOSI as a doublet should be an additional standard of care in this space, which already has Abiraterone with respect to latitude data, which has long-term OS data, apalutamide and enzalutamide, which has long-term OS data. Darolutamide OS data is still maturing, but I think it scores over the other agents in the form of safety profile. If you want to avoid steroids, especially in a country like India, which is full of diabetes, and you want to avoid seizures and falls and risks in your elderly. With that, I would like to thank all of you for a patient hearing. Thank you so much.
Thank you, Krishnamani sir. You have clearly explained us how the treatment evolved over a period of time. What is the importance of those trials? Why they have designed like that? What is the reason? Now where we are using a triplet and a doublet, choosing between a triplet and a doublet in a metastatic HSPC, understanding where the triplet is needed to prevent that aggressive progression to the CRPC where they have a poor prognosis, and where we can de-intensify the therapy. So intensification is good, de-intensification should also be considered. Who doesn't require very low risk, low volume, or who won't tolerate docetaxel, so we shouldn't rush to give a triplet in them, and we should settle down for a doublet. And in the doublet, the agents which are being approved and which would be the better option if you are having all the drugs in your hand, so which would be the better one based on the side effect profile and the evidence what we have right now. And thank you for that, sir, once again. So now I would like to um, go ahead with my presentation, a case presentation. And this case would be like combination of both the talks which we heard just now. So let me share my slide screen.
Sir, if you want, I can share the slides, sir.
That's fine. Just give me a minute.
Okay, sir.
So I hope
Yes,
the
sir.
slides are visible. Yeah, good.
Slides
Thank
are
you.
visible, sir. And you're audible, please.
Yeah, thank you. So this is the case which I had treated. He's a elderly man. We consider 68-year-old with a hypertensive and diabetic history. He presented with lower urinary tract symptoms, and he had no other history like loss of weight or appetite, and there is no family history of cancer, and his performance status was good at the time of presentation. With these symptoms, when he visited his family physician, he was advised an ultrasound abdomen, which showed a mass, but peculiarly it was showing us in the ultrasound, showing like it is originating from the rectum rather than the prostate. And the tumor markers were sent, both the CEA and PSA. PSA was more than 100, and after which it was he was advised to go ahead with transrectal ultrasound in April 2023, which also suggested the mass is originating from the posterior lobe of the prostate rather than the rectum. And eventually, he also underwent a CT scan, a huge mass of 7.5 centimeters originating from the prostate, posterior lobe of the prostate, which is indenting onto the rectum. So, followed by which he underwent a biopsy, trust-guided biopsy, showing an adenocarcinoma with a Gleason score of 8. And a PET scan was done, which also suggested a prostatic mass. Along with that, there are multiple bony lesions. So this is the important, this is a PSMA PET scan. So this is the importance of the current PET scan. Sometimes we may miss these in the conventional scans because these are very sensitive. We would like to pick up many more meds, and obviously the volume and these things will differ, volume and risk. So this could detect some of the bone lesions and as well as the multiple liver lesions. So he's an elderly man who presented with a metastatic prostate cancer of adenocarcinoma Gleason 8. With this, he was diagnosed to have a de novo disease, which is a high volume because of the visceral mets as well as the number of the bone lesions, and high risk because of the visceral mets and as well as the Gleason score. So he is the right candidate for the triplet. So age doesn't matter. Generally, it's not a limiting factor. If the performance status is good, if they are eligible for a docetaxel, and if they fall into this category, even the metastatic de novo also would be as a high risk now these days. So if they have these factors, we would consider, or at least we'll counsel them the availability of the triplet regimen. And because he had a very good performance status, we decided to go ahead with the triplet, explain the importance of giving a triplet regimen in this bad prognostic, bad prognostic disease, where we know that once they progress, within 3 years, they are going to progress if you are going to only give a doublet. So treating a CRPC is very difficult, and the number of available options are also very less, very limited, and it's not durable also. So after counseling about the chemotherapy, they were very reluctant about chemo, but they got convinced as a family doctor, like, one of them had in the family, they have a doctor, so he could convince them properly. Then the treatment was started with the bilateral orchiectomy, and the docetaxel was started. And even though his BSA was around 1.9, we capped it to 120 mg of docetaxel, along with the darolutamide was started after a week. Then after the first cycle, he had a significant diarrhea and fatigue. We know that these side effects are because of the docetaxel. As darolutamide, generally when I speak to patients also, I tell them it's just a placebo. Whatever we have the evidence, the side effect profile, it is equal to placebo. So it is not because of the darolutamide, it's because of the docetaxel. So somehow we gave the supportive care and we went on to the second cycle, with a lower dose, only 100 mg, but significant diarrhea and fatigue again. So with this, the monitoring parameters, like initially the PSA was 135, it is not 1350, it's 135. With the orchiectomy itself, within a month, it fell down to 21. Then with the continuation of the one cycle, you can see the PSA levels falling down to 0.01, which is like, subnormal levels. Very good response of PSA. Seeing this PSA report and having the side effects of the docetaxel, the family also decided not to continue the docetaxel because such a good response, and they understood the efficacy of the darolutamide in this setting, and the chemotherapy was withheld totally, and the darolutamide was continued with the standard dose of 600 mg twice daily. So this was done for almost like 4 months, 6 months, where you can see that, like, initially we started in May. So in October, the scan was done, a PSMA PET scan was done, where there is a complete metabolic response and partial morphologic response in the prostate, and a partial response in the liver lesions also. So it was a very favorable response to the treatment, and he was continued on darolutamide, and the PSA was repeated once in 3 months, where initially you can see the orchiectomy itself, it was fell down from 135 to 20. Then second month with first docetaxel or a triplet therapy, it is 0.1, then slowly 0.02 in the third month, then it went down to the subnormal levels. So he was continued the darolutamide like that for 2 years, where in January, you can see there is a rise in PSA. It has been confirmed after 4 weeks again, the doubling of the PSA or the rise in the PSA. It was consistently more than 3, and it was like slowly increasing. There is a chart which the patient prepared, but this is not there. So it was slowly raising from 0.01, it went to 0.07, then 1.2. Still we waited. So because we don't jump into the treatment, change in the prostate unless there is a significant clinical symptoms. So with the rise in the PSA, a PSMA PET scan was repeated. It detected the new bone lesions and a left lung nodule, and the prostate and liver lesions were stable. So these were like completely new lesions. So generally what we think when the PSA is not very much raised, like, 30, no more than 20 or 30, but they have a new lesion, we tend to see that is there any change in the histology. So the biopsy was done, which was again consistent with the adenocarcinoma. And now he is like MCRPC. So he progressed from MHSPC to MCRPC within 3 years, within 2 years. That shows how aggressive or how bad the biology of the disease is. And of course, maybe if you would have tolerated the docetaxel for all the cycles, probably the progression-free survival would have improved, because we could do only 2 cycles of docetaxel and continued on darolutamide for the rest of the time. Then the other molecular markers who have been evaluated, what we generally do in the CRPC setting, the BRCA testing, HRR mutation profile, and MSI, all are like wild and negative. So we didn't have any other option. but this time they could again re-challenge with docetaxel, because now we told them that we'll go with a little lower dose, maybe different formulation with less side effects, maybe, and it was planned for only once in 2 weeks, unlike the previous once in 3 weeks. Though he received 8 cycles, once in 2 weeks like that, and you can see the PSA. Sorry. Yeah. So it fell down to 0.04. Very good response was there. And May scan also suggests to have a partial response to the treatment. But after 3 months, again, there was a rise in the PSA. Then a PSMA PET scan was done. Again, we could see the activity in the most of the lesions. So now we don't have much options because all the molecular profile is negative. So advised for and not for cabazitaxel at that point. Sorry. So, and he was advised for lutetium therapy. So now he received 1 dose of lutetium in January 2026. He is on observation right now. Like, he is just on follow-up right now. So, but still he wanted to continue the darolutamide, but there is no data to continue, like, when they've, progressed on triplet, I could say. So now he is on lutetium therapy, and symptomatically he is doing better, and his PSA is also under control. So this case why I presented, one is not to miss the high risk or a bad disease upfront, because that is the time where they can tolerate the triplet therapy. Once we lose the opportunity initially, when they progress within 3 years or 2 years, at that time may not be able to tolerate docetaxel at all in the CRPC setting. So it's better to utilize the drug when they require. That is, they should have a bad disease. They should be able to tolerate the docetaxel. That is the place where we should counsel them for the triplet therapy. And now these days, what I'm saying is we should start, we'll start with 1 or 2 cycles. We'll see if they can tolerate good. Otherwise, we'll stop and continue with the ADT, ARPI, because now we have a run-out study or multiple other studies are there, which Manish sir clearly explained, where that also is fine. It's not like something mandatory we have to give a docetaxel. Who can't tolerate docetaxel, we can withhold and continue with the ARPI and ADT, because here we need a good quality of life, because there, in that age and with comorbidities, we know that what all the complications they develop with the treatment or with the disease itself. So keeping that in mind, so we need to counsel them. Whoever is fit enough or whoever require the triplet intensification, we need to counsel them. Whoever is not, so don't push them for a triplet therapy, because we understand that docetaxel is efficient only in the high volume or a high risk disease. There is no point giving docetaxel in a very low volume disease, especially, or a low risk disease. Maybe a little benefit may be there in the the literature wise, but in the practical, when you see in the practice, I think it's not much, like, it's the benefit is very modest. It's not like very significant. So, and hence we need to choose the treatment regime very clearly initially itself based on the risk stratification. And the re-challenge of the docetaxel may be what we do in the CRPC also. Once they initially receive docetaxel, and when they progress, we can give an ADT in the CRPC, ARPI in the CRPC setting. And when they progress again, we can re-challenge docetaxel. That's what the evidence what we have. But what I'm spoke about is in the MHSPC setting, because initially we couldn't complete the planned cycles of docetaxel. We tried to reintroduce the docetaxel and succeeded, with the triplet. But it was not the durable response of what we got. So and hence we have to give the best drugs upfront, so that we'll have a very good progression-free survival. So, and we understand that the side effects, whatever we develop, is because of the docetaxel and not because of the darolutamide. Darolutamide is considered equal to placebo. So with this, I would like to thank once again the speakers, the Bayer. And if any questions are there, we can take up, and Mani sir and Venugopal sir also can answer them.
Sir, I think Manish sir is not available. But let me check the chat box, sir, if any questions are there.
Yeah. So let me close my screen.
Sir, I think there is no questions in the chat box. Sir, if you are comfortable, then we can have a small discussion with Venugopal, sir.
Yeah, sure, please.
Yeah. So I hope the slide is visible, sir.
Yeah, it's good.
So
Just keep it in a presentation mode.
yeah.
Yeah. So the first question is regarding the doublet or triplet. So what factors guide your choice between the doublet and triplet? Venu sir, so how do you choose in your practice?
Yeah, Dr. Chaitanya. So basically, as you have already alluded, so those patients, I mean, definitely age should not be a criteria. I mean, let us be realistic and practical in this discussion, I guess. So age should not be an issue, but at the same time, definitely yes, we need to assess the ECOG PS and fitness of the patient. So the one liner, what we can always tell is now those patients who are fit enough to receive docetaxel, definitely we would like to go ahead with triplet without any hesitation. What do you feel, Dr. Chaitanya?
Initially, I was like little scared, sir. In males, more than 70, 75 to give a docetaxel. But, we see a lot of, females in the, breast cancer where we give TCH regimen, combination of carboplatin, docetaxel, and anti-HER2, and they tolerate so well.
Yeah,
So then, it's
definitely.
like,
Although docetaxel, we would like to cap it off to 120 mg for those patients also. We go up to 140 also, not more than that.
yeah. So
Yeah.
earlier we used to use these docetaxel in lung cancer patients in the second line would, see the side effects and all. But I think upfront in prostate, whoever is fit, I think they should be given docetaxel.
Yes, definitely.
And the doublet
Triplet.
also.
What I mean, triplet. Yeah.
Yeah. So doublet also, I hope you also stopped practicing doublet with
Yes.
docetaxel, right? It's
Yes.
just
Yes.
ARPI and ADT.
Yes. True.
Yeah. So in your clinical practice, how important is the combination of this, progression, delayed progression, and improving the quality of life when you're treating the de novo metastatic HSPC?
Yeah. So, I mean, this is again one more important point what we have discussed 2-3 times. But importantly, what we should remember is treating a CRPC patient is very, very, very difficult. Options we have, but the magnitude of benefit with any of the available agents is very limited, non-durable. So we need to choose very wisely in the metastatic hormone sensitive castration naive setting itself. So that's the importance again. What comes the importance of triplet. Yeah.
Yeah.
So in specific, if you are talking, uh, as this is a disease of an elderly, so definitely Daro is very, very promising agent because of all those factors, beneficiary factors, what we have discussed over the other two agents. Like apalutamide has a risk of skin rash and hypothyroidism, and enzalutamide seizures and falls and CNS very high. When we don't dare enough actually those patients to put them on enzalutamide actually in view of high CNS penetration of the drug. And I was just going through the literature. It's a strong inducer of CYP3, cytochrome P450 enzyme. So it has actually interactions with many drugs. So definitely Daro scores over.
Yeah, I feel it's very important. The delayed progression is very important. So when we see a CRPC, MCRPC patient, the symptoms, the complaints what they come up with, it's very, we can't even give a, symptomatic benefit to them, symptomatic relief, and they'll be frustrated. It's like such a stormy course. I think we should able to delay the progression as far as possible when they are in MHSPC, not to go to the CRPC setting. And quality of life, as you said, it's very important. And we know all the drugs what are the side effect profile. And once again, to tell that darolutamide is equivalent to placebo. That's what I generally tell the students and as well as the patients, so that they will understand how important it is, the side effect profile, when you are talking about the side effects compared to the placebo. And Daro doublet, you said, maybe a low volume where we can avoid unnecessary toxicities and all. Maybe doublet is better. And now keeping the efficacy points, I think all of them are having an equivalent efficacy, but the side effect profile is much better. As the side effects are less, they are going to be on treatment for longer period of time. That's what we see in the chronic diseases, where the adherence to the treatment is better, then definitely the survival is better with a good quality of life. So side effect profile comes to the first when you are treating a chronic disease patient rather than the efficacy, what I feel. And what are the challenges, sir, available for a doublet and triplet in practice? This is like more practical.
Yeah, the challenges definitely when we are dealing with triplet, we need to remember the side effects of the docetaxel, risk of fluid retention, edema, as well as febrile neutropenias and severe fatigue. All these definitely hamper the quality of life. Yeah.
And what about the financial, like,
Yeah.
if you are going to go for a darolutamide as a
Yeah,
preferred agent with
darolutamide
triplet,
definitely is this finances are the big issue. Otherwise, nothing else in our back of minds. We are
correct.
planning.
Yeah.
Yeah.
And with the support program, what we are getting, I think it's
Correct. So
doable.
with
It's not like,
good support program, definitely we
yeah,
should be able
it's
to do.
doable. Yeah. So in a patient with non-metastatic CRPC with multiple drugs, and the how do you select your ARI? Again, the drug-drug interactions.
Yeah. So if especially if you're talking about cardiovascular effects, definitely I would be skeptical in the usage of abiraterone, as we know. So it's the one drug which causes mainly metabolic impacts, like in terms of hypertension, hypokalemia, usage of steroids, diabetes worsening, all that. So definitely in those patients, we would like to avoid abiraterone by any means. So before the availability of other drugs like apalutamide and darolutamide, we used to go for Enja in place of abiraterone, those who are at high risk for cardiovascular risk. But now having got the darolutamide in our kit, definitely it's powerful with all those factors what we discussed.
Right. And Sandeep, can you go for next slide?
No, there is no other slide. That's all. These are the
Okay, that's
questions.
good. Thank you. So just to summarize, I think what we discussed is by Venu sir, that is the triplet regimen by Arasen's data, the how it is different from Peace data, the study design itself, and as well as the baseline characteristics, and as well as the how robust the data is with the triplet. So if you think about triplet, it has to be a darolutamide. It is like that now. The evidence what we have, and whoever is docetaxel fit, it's a triplet wherever they require. So these are the some of the things what we can keep in mind without any confusion. And don't over treat the patient where they don't require a triplet. Just give doublet, they're going to do well. So, and we understood the side effect profile also of the darolutamide. Again, to reiterate that it is equivalent to the placebo, what we have seen, and with the least drug-drug interactions. And so now we have in various settings the approval of the drug. Earlier, it used to be only with the triplet. Now we have with the Aranote, that is a doublet which has been approved. So with this, I would like to thank once again Bayer and the organizers for the opportunity, and I thank both of my speakers, Venu sir and Krishnamani sir, for their clear, presentation on the data of darolutamide. Thank you once again.
Thank you, Dr. Chaitanya. Thank you.
Thank you, Dr. Chaitanya sir and Venugopal sir, on behalf of Bayer Oncology, for taking your time, and excellent presentation by Dr. Venugopal sir and Dr. Krishnamani sir. And it's a great case, sir. Again, Chaitanya sir. So with this, sir, I don't see any questions in the chat box, so we can conclude this session, sir.
Thank you. Good night.
Yeah. Thank you,
Thank
sir.
you.
Good night.
Good night. Yeah.
Technical team, now we can end the session now.
Okay, sir. Thank you.
Thank you.